So now I would like to request Dr. Girdhar Gyani to please address the session and please provide us with the insights on the potential in enhancing patient safety and outcomes by integrating CDS in surgical, and what are the possible key challenges or opportunities in different operative phases to improve clinical outcomes and how we can reduce the complication along with some examples. Over to you, Dr. Gyani.
Okay, thank you very much. So, as I understand, today's discussion is around the patient safety and use of technology. How actually can it really improve the patient safety in our country? Now, I think all of us are very aware about it that quality in healthcare, actually, quality and patient safety are synonymous. Actually, they are the two sides of the same coin. Now, in healthcare, we define the quality in two ways. One is the clinical quality, and another is the service quality. The clinical quality actually here concerns around with the patient safety. So now, actually, if you really go back into the history, we had the physician, the name of the Codman. Actually, he started, this end result concept because he was the doctor who really said that quality in healthcare matters only around the outcomes. So if the outcomes are good, that means the quality is good. So actually that, concept which he evolved way back in 1916 actually was prevailed, and another initiative came from American College of Surgeons. The American College of Surgeons picked up this concept, that end result aspect of the Codman, and they in the country, USA, they started the hospital inspection program. And this was in around 1918. 1918, the American College of Surgeons, they started a inspection program. They called it later on standardization program. And they kept on doing this program till 1950. So I'll say this was the really longest program run by an association, you can call it, American College of Surgeons. Later on, American College of Physicians also joined hands. Further, the Canadian Association of Physicians also joined hands. So gradually, it became a very big body, and they took the ownership of driving the quality and patient safety in America and in Canada. These are the two things. And then, actually, what you call nowadays accreditation. The accreditation was evolved from this ACS model, American College of Surgeons. This model was picked up by a body which today we call as a Joint Commission. The Joint Commission in 1951 launched the program on the absolutely the same line the way American College of Surgeons were doing. But in the meanwhile, the main important person actually would like to mention today is that the based on which the accreditation program is being run, it was the Donabedian. The Donabedian is another doctor. He was also a physician who actually said that this end result is okay. But what is the point of suppose end results are not good? We have to go back. We have to do the root cause analysis. So he then came up with a model what we use today world over: structure, process, and outcome. So his idea was that once you define the structure, for example, if you want to design a manual, or you want to design a safety committee, or you want to design the medical equipment, anything related to, once you create the structure, including the documentation. So once the structure is created, then he designed then what should be the process. That means how do we deliver, and then the outcome. So the theory of Codman was finally modified into the structure, process, and outcome. And that today is followed world over, including our own country. So in our own country, the patient safety movement picked up only in 2005, I will say, when the question was raised in Parliament that medical tourists were asking this question to the government of India, that when we want to go to the Indian hospital for medical treatment, how do we choose? Do they have any quality accreditation program? And that question from Parliament was referred to Quality Council of India. And then, of course, we started the process of designing the accreditation system, what we call NABH. And this NABH came in 2006. So let me put it this way, the American accreditation started in 1951 and Indian accreditation started in 2006, almost 50 years later on. But even today, the third largest cause of death in USA is attributed to medical errors. So the point which I'm trying to draw here is that accreditation is not really the patient safety. Accreditation is merely designing the framework on which you have to build the quality and patient safety. So the once you design the accreditation system in the hospital, then the ownership of this accreditation has to be taken by all the stakeholders and mainly by the physician and surgeons. Once they take up the ownership of the procedures or processes or SOPs designed in the accreditation program, the rest of things will follow automatically. So today I can safely say that in India, I think more than 20,000 hospitals are either following full accreditation or what we call entry level certification program or empanelment with the CGHS and ECHS. So you can say that 20,000 hospitals in India, they are aware about the accreditation, quality, and patient safety. And this movement today, I think all the doctors today are aware about what is accreditation. In fact, I was in Bhubaneswar about 1 week back, and very young doctors, they were talking so freely about the clinical indicators, how do we measure the surgical site infection. I was very happy because these things are not covered in the MBBS curriculum or even the PG curriculum. But today, I think all practicing doctors, they follow the patient safety norms. So I think thanks to NABH, today the quality movement has really improved, I mean, percolated down everywhere. Now, coming to the subject of technology, very briefly, because experts will speak on this topic, that if you really go back to independence time, our average life expectancy was around 33 years. And today, average life expectancy is 73 years. I think this advancement has taken only because of the simple reason that we have improved the diagnosis. And diagnosis is improvement come through the technology. And of course, our specialization has also helped to improve the medical treatment plans and everything. I mean, put together our hospital today are state of art hospitals, and we follow not only the standard treatment guideline, but we make use of the technology. The main issue, which actually today people will be talking about here, is that the clinical decision support system, basically in the teaching hospitals or in the medical college hospitals, senior residents, when they really want to look into the particular diagnosis, the clinical decision support system, which is based on the artificial intelligence and which has stored the thousands or lakhs of the similar cases which have come, and so the clinician is able to really go through and try to match with the diagnosis of particular patient with the data stored in the clinical decision support system, and he can really arrive at that what protocol he should follow, what actually treatment plan he should follow. So this is a great help coming to a senior resident. Particularly, will I will say my own concern is that the internship in the Indian hospital of late got diluted for the simple reason that all our undergraduates were preparing for the PG classes, PG admission, and they were not able to really focus on the internship. So, but I think today that cycle again has reversed because we are able to define the admission in the specialization well even immediately after completing the MBBS program. So I think now again we are going to be back on the track, but coming to the point that clinical decision support system is a good help. But let me say here that it is not the master. Master remains the clinician, but this provides the excellent opportunity and the you can choice, you can say, to clinician to arrive at the right treatment plan. So I think technology, of course, otherwise, for example, I was the other day listening a talk at the AIMS on the genomics and personalized medicine. This is another area which is coming up in a very big way. But I think I will not go into much of the technology. Let me first hear the experts because we have very limited time. There are three experts panelists who are going to talk about it. But all in all, I can say that healthcare in the technology has come in a big way. And in USA, they now call the engineers as a clinical engineers. They don't call them the biomedical engineers because they work hand in hand with the clinician. And the use of technology might appear to have increased the cost of delivery of the healthcare. But I think let me again remind the same point here that if you are able to save the lives of the people, I think this incremental cost doesn't matter at all. And my last line is that quality or use of technology may cost, but absence of technology, absence of quality, absence of patient safety may cost the life. So I think this message has to be heard loud and clear by the community at large who keep on saying that the cost is high. But I think again, I want to remind them that this is affecting the life of the community, life of the population, life of the human being. And this is what we have to accept, and we have to accept to include this kind of expenditure in our budget. The way we include in the budget the cost of education of our children, our household, rent, everything. Now I think we have to include some cost on our own healthcare. So I think with this, I will like to go back to I think the panel and let us hear from them what they feel about use of technology into the patient safety. Thank you very much.
Thank you, Dr. Gyani, for providing us with the valuable and informative insights on patient safety progression across the country and how to improve care and quality and patient outcomes with CDS system. So now I would request all the panelists to begin with the discussion with the topic driving in implementing patient safety in India by improving care and quality outcomes with CDS system and to provide us with expert insights on implementation of evidence-based medicines, reducing medications errors and much more. So now I would like to request to Dr. Gyani to lead with the panel discussion ahead. Over to you, Dr. Gyani.
Now, who will be moderating? You will be moderating, or somebody else, or I have to moderate?
You can start with that.
I think the kind of people who are in front of me, really, I don't have to really trigger them. In fact, my point will be very simple. That I think each of the panelists, I think we will give them, let us say, 7 to 10 minutes of time. If they want to make the PowerPoint presentation, they are welcome. And basically, I think they should dwell in the two parts. One, what is the status of patient safety in our country as per their wisdom? They can tell us where is the patient safety kind of, how are we feeling about the patient safety, whether the patient safety has been established as a culture within the hospital among the clinician. That is one part. And second part they can explain is what kind of technology they are presently using and what is the future of technology and in general and particularly have they used the clinical decision support system, if not why they have not been able to use, what are the limitations. I think these two parts, so one is the general patient safety, another is the use of technology including the clinical decision support system, their own experience, their own expectation. So I think let us start with Dr. Ganeshan, or whosoever want to start. Who wants to start? Let us see. Who is going to use the PPTs?
Uh, Sorry, I'm going to use a PPT, but in the sequence, it's Professor John who's first. Is it okay if
Okay.
we request him
Okay.
to?
So let us start with Professor Ganeshan.
Oh, okay. Can you see my screen, sir?
Yes.
Okay. um, Respected Director General of AHPI, Dr. Gyaniji, and esteemed panelists, I'm uh, humbled to be part of this esteemed panel discussing on important theme of patient safety. I'll share some thoughts on my understanding of, as Gyaniji was saying, where we are now and where we would like to be using technology. Um, when I look at patient safety in India, where it is today, the focus is on the current crop of healthcare professionals. Most of our energy is spent on raising awareness about safety in care delivery. And I'm sure there is a lot of effort which is put into carefully considering and incorporating safety in all aspects of care delivery. And most importantly, where the work needs to be done in sort of much more is making safety a part of organizational culture. I suspect that takes time because it is not just about leadership's intention and the processes and the structures in the process, but it is much more individual involvement, every healthcare professional's involvement. Looking at where patient safety, how do we plan for patient safety in India for tomorrow? I strongly feel that this is essential to make Indian healthcare sector future ready. And patient safety, I would be a strong advocate for making patient safety as a priority from first year of MBBS and all healthcare courses like nursing, pharmacy, allied health professionals, etc. Delving into just the two themes separately, with respect to patient safety for today, I think it would be good to consider initially the patient's perspective as to what they want. I guess most of the patients would want a safe, quality, and affordable care. Are we able to provide that? How tuned are all our organizations to deliver this? Is the key question. Echoing Dr. Gani's earlier statement, I also would consider safe care is the first step in improving quality of care. We cannot talk about quality without ensuring that the care is delivered in a safe way. I also see a unique Indian challenge is the societal outlook to risk and safety. For example, the common man on the street doesn't always wear a helmet while riding a two-wheeler or seatbelt while driving in a car or people crossing the railway lines. So that is the society all the healthcare professionals come from. So if you want to change the attitude of healthcare professionals to become very aware of safety in healthcare practice, that's has got an extra step of challenge in India that we need to overcome. All our healthcare organizations, I'm sure, are making concerted effort to do that. And the other big change in terms of what we do in healthcare organizations is we are looking beyond just treating diseases to preventing them, where it is not very obvious and there may be a lot of subtle things. So, unless there are proactive steps which are employed, the safety aspect may be compromised. In terms of the resources available to us to help deliver safe care, I can think of tools like WHO checklist for surgical patients in acute care and guidelines overall in sort of covering multiple aspects of healthcare to ensure most often minimum standards, but sometimes for improving standards as well, and evidence-based practice for the self-directed lifelong learners. In terms of implementing evidence-based practice in hospitals, again using a CDSS kind of system, just drawing from my own experience, ours is a 630-bed multi-specialty hospital in one of the metropoles, running 10 national board accredited courses. I have about 40 plus trainees in our hospital. And we run evidence-based practice forum as a monthly meeting for over 2 years since February 22. This again drives safety and quality, and I would illustrate to you how it is. In terms of the structure of this particular academic activity, the support I offer is a 1 hour preparation or facilitation, where a PG trainee comes up with a set of questions from outpatients, inpatients, or operation theatre. They learn to convert to paper format. Then she learns to identify the best type of article to answer this question, and then learns to search for the best article and learns to appraise one of the papers using CAST checklist. This is different from the conventional journal club where you just pick an article and just appraise. Someone who is trained this way will be able to start with a bedside question and move towards identifying the best available evidence. That is a big difference. So overall, what is the intended impact? Is that the trainee understands the basic steps of evidence-based practice. More importantly, as part of this journey, they just not just appraise one article, they also gather related information, and this is shared with the clinical teams to impact on patient care immediately. So although this is just starting as an academic activity, it impacts on patient care as well. To give an example, our obstetric trainees wanted to look at the question of gestational diabetes and pregnancy-induced hypertension. Having reviewed the evidence, found that neither of these entities disappear after 3 months, and there is a subpopulation of pregnant women who continue to have problems with either diabetes or hypertension long after, way beyond 3 months. And there is good evidence for this, and that was presented to the obstetric team. And since then, our team of obstetricians have changed practice, and we've got a leaflet also advising patients to go and seek further screening and monitoring relating to these conditions, which are important and can cause morbidity in later life. So that way, what started as an academic activity has impacted on patient care, patient safety in our hospital. What are the perils of not following the evidence? I can very readily recall one of the strand of thoughts from the recent COVID-19 pandemic. Many of you may recall this article published in New England Journal of Medicine in May 2020, talking about the preliminary report on remdesivir for treatment of COVID-19. It clearly states that remdesivir patients who receive remdesivir have a median recovery time of 11 days compared to 15 days in those who receive placebo. So compared to placebo, it reduces hospital stay by 4 days. Unfortunately, a large proportion of people across the globe got carried away by the conclusion where it said remdesivir was superior to placebo, which means you get nothing. And we saw these kind of massive crowds standing in front of units which made the remdesivir available to public during COVID pandemic. What bigger compromise of patient safety and public safety can be there? All because people did not evaluate the evidence rigorously. They went by the preliminary report, which was a very poor quality kind of finding of reduction in hospital stay, very non-specific finding. But unfortunately, that drove people sort of absolutely up the wall, and this is the kind of crowd we saw. A few months down the line, there was a World Health Organization Solidarity Trial Consortium published this article again in New England Journal of Medicine, and it concluded that remdesivir, hydroxychloroquine, lopinavir, and interferon regimes had little or no effect on hospitalized patients with COVID-19, as indicated by overall mortality, initiation of ventilation, and duration of hospital stay. This is one of the most powerful evidence which came through during the COVID era, sort of blowing the myth of multiple agents which are used. Interestingly, this is a kind of key summary of the COVID-19 remdesivir story. The remdesivir received fast-track approval by FDA initially for only severe COVID-19 patients, and in August 2020, all hospitalized patients, which was controversial. The initial clinical trial, we need to remember, was done by US CDC and pharma company, and it showed modest reduction and duration of hospital stay for severely ill patients. But the Solidarity trial showed benefits only for a subgroup of hospitalized patients requiring oxygen, but not those who are ventilated. There was no convincing evidence in any life saved in any clinical trial compared to the impact of a very cheap drug, dexamethasone, which had a very important, meaningful effect. And remdesivir for all this wasn't even cost effective. A 5-day course costed between 2,300 and 3,000 US dollars. So, with that in mind, I would strongly advocate that a rigorous sort of evidence-based practice would make our clinical practice safe today. And we need to start training all doctors from the postgraduate time to incorporate it into their day-to-day practice. Looking at patient safety in future in India, there has been good progress made to improve the doctor-patient ratio in terms of the number of medical colleges, which have doubled from 387 to 766 in the last decade, and also PG medical seats, which have doubled from 31,000 to 73,000. This news clip was from the newspaper a couple of days ago, which many of you may have seen. Although we have done well in terms of increasing the quantity, the big question remains to be answered. How are we going to deliver quality medical education to this group of medical students and postgraduate trainees? That is where I think there should be a massive focus on patient safety, even in medical education. I would go to the extent of saying that we need to have a dream. I would like every one of you to dream along with me that in the years to come, every Indian MBBS graduate will be competent to treat at least 100 common health problems seen across India. If you ask the question, is that the case today? I'm sure many of you will agree that that is not so. That is because we have not put patient safety at the heart of medical education. I think we need to do that. Medical curriculum across India should be redesigned, starting from teaching and also assessment of undergraduate and postgraduate students, and prepare them to deliver safe care, which will be high quality care. Thank you very much for the opportunity.
Okay, thank you very much. Actually, as you were saying, that in fact we are working many times with the NMC. In fact, I remember in 2014, we used to have 50,000 MBBS seats. And I think if I remember, 18,000 was the PG seats. And now, as you are mentioning, the PG seats have become 73,000. But the MBBS seats are now, I think, 1 lakh, around 10 or 15,000. So the gap still remains, though the gap has narrowed down, but the gap still remains. And India's problem is the shortage of the specialists. And as in the parliament 2 months back, they gave the data in the community health center, the four specialties, the pediatric, general surgeon, general physician, and gynae. I think everywhere the shortage was around 80%. But of course, that is in the community health center. But even otherwise, we do not have the specialists for serving in tier 3 towns. So that remains a major challenge for all of us. But anyway, I think you have provided a very good statistics, and the DNB program, which you mentioned, also is helping in providing us the specialists. Now, with that, let me move to Dr. Suviraj, and let us hear from you your opinion about the status of the patient safety in our country. And in respect of the clinical decision support system, I think I would like to hear from you that if you have any experience or example of use of clinical decision support system in your surgical settings, what has been that experience? And can you also provide to our delegates or the viewers how actually that is really helping in diagnosis, investigation, and also giving the right, in arriving at the right treatment plan? So over to Dr. Suviraj.
Um, Thank you very much. I hope you can see me. I'm trying to connect the. Can you see me, sir?
Dr. Saviraj, we cannot see the video of yours.
Okay, just a minute. I'm just trying to connect. Okay. Yes, can you see me
Yes,
now?
yes.
I was trying to share my slide, and I'm trying to see how I can do that. Thank you very much, sir. I think I'll take an extempo. Uh, Thank you very much for prefacing this very important topic. This year, the global patient safety theme is improving diagnosis and patient safety. You very correctly highlighted the background in India, and Professor Ganeshan has very kindly given us a very nice context. This setting. At Sir Gangaram Hospital, I'd like to narrow this down to one topic to give you an idea how we're working detailing in patient safety. Uh, we know from that top three adverse are namely the ones that are known are adverse events related to drugs, adverse drug events, hospital-associated infections, and hospital-associated venous thromboembolism. These three we call the big three, and in total, including the other ones, they cause about close to about 5 lakh adverse events in India every year by WHO's estimation, the last publication 2013. So I assume it's much more now. We focused in the surgical department already on infection prevention control. So I think in the last 5 years, we focused very objectively in the prevention of venous thromboembolism as a system issue. For decades, certain departments and specialists have been doing this very well. But especially since April 2020, when the fifth edition of the NABH in Standard and Objective Elements COP16E has very explicitly mentioned that we need to objectively prevent VTE in our patients, we have now a hospital formal VTE prevention protocol. It's a clinical care pathway, and I would say a clinical decision support system to prevent VTE. It's based on guidelines, based on well-established risk assessment scores, as well as a clinical order set. It's an algorithmic attitude to prevent hospital-associated VTE and also pick up community-acquired VTE in patients who come for surgical procedures. So this is actually implemented. The turnaround time is 1 hour after admission. The history examination is completed within half an hour. This form has to get completed within an hour. This currently is in the paper form, but we are now having an online format, which will be soon implemented, hopefully in the coming months. So that is going to give us, online data as well for individual patients. This forces clinicians to do an objective assessment based on well-established clinical evidence. We have, for example, the score to assess for pre-existing DVT and pulmonary embolism, the Wells DVT and P scores, which objectively rule out suspicious patients, deep vein thrombosis, and pulmonary embolism. Once we've objectively ruled them out, check effective risk of deep vein thrombosis and pulmonary embolism by using a Caprini risk model. This is a 40 variable long model, and this is based on well established clinical factors. This evidence is over 70 countries and 200 publications. And then we also do a bleeding risk assessment based on a well accepted publication. And then we funnel it down to a common scoring system to create a clinical order set on the last page. This has to be completed by the admitting resident and the duty consultant within 1 hour of admission. Now, once this clinical order set is in place, the nursing staff carry out the orders. We also provided media out in exceptional cases where, in the situation of a high-risk patient, we don't give pharmacoprophylaxis. Now, once this is implemented, is repeated in terms of assessment every third day for an average patient who's stable, every day for an ICU patient, and at discharge. We now actually capture compliance data to the protocol on a daily basis across the hospital on an online format. I'm happy to tell you our average increase in compliance the last year has been about 10% increase. So it's going up. In the UK and US, they tell us that to achieve even 80% compliance, it takes about 2 to 4 years of hard work. So we actually have real-time data, point assessments, and as well as by daily online surveys. Our main challenges have been education, in terms of getting consultants and residents to come on board. And our response has been, again, education, retraining, and intense workshop-based education. We also provide rapid feedback monthly data to the hospital, not in events, but also in compliance data in terms of high as well as legal risk for consultants, departments, and hospitals. So high legal risk areas are flagged to the leadership of the hospital, and we send reminder memos to individual consultants when they had an adverse event, especially when a compliance has been found lacking. We are focusing intensively on training because we see that as the only way to go forward as EMR enforcement of the protocol. Enforcement of the protocol. Without EMR enforcement of this paperback protocol, we believe it'll be hard to achieve 100% compliance. And we know from Indian as well as, I would say, Western evidence that EMR enforcement is the only way forward to do some of these critical steps in patient safety. And I must remind you that hospital-associated venous thromboembolism is the globally and India's leading cause of preventable hospital deaths. In certain areas, such as bariatric surgery, in which I am a surgeon, it is the number one cause of death in post-bariatric surgical patients. It is the number two cause of death in oncology patients, as well as a prominent cause of death in trauma patients, ICU patients, as well as in those undergoing hip and joint and knee replacement surgery. So we now have this on our every file, and it's soon coming onto the EMR format. And we hope that our education system will be supported by the CDSS getting incorporated into our EMR, which is the next step, I believe, in our integration of technology along with clinical evidence. It's an evolving field. We have a complete team of 2 VT control nurses along with me as the lead for this at our hospital, and a complete the top level commitment is very high. And we soon will be celebrating our annual, the 8th of December. It's actually the 13th, but we're doing on the 8th. And we're moving, our next big step is to educate patients and make them the primary stakeholders in this safety by including them also in the screening process and scoring process. So they also provide their own assessment right now in a paperback format, but soon in an online format. Thank you very much, sir.
Thank you very much. Yeah, because you are able to give us the practical insight what is happening, So I think we'll come to the round of discussion in the end. So let me go to Dr. Suresh now to give, his insight about how actually it has been helpful to him. So over to Dr. Suresh.
Hi, thank you, Dr. Girdhar, and great leads by Dr. Ganeshan and Dr. Sivaraj. So I come at a different point of view as an administrator of a hospital. We do have 10 national board departments, and we're a multi-specialty hospital. And we've been having CDSs for quite a few years now. My take on this is, of course, there are 2 things. One is, of course, the cost. It always boils down to the cost when you're an administrator and someone wants it. And what is the utility being derived from it? Like Dr. Girdhar mentioned, quality comes at a cost, and we need to be able to absorb it. Ideally, it's something that if like in the NHS, everyone inside the country, in UK, can access these tools. Like the Indian government has actually signed up for something called SNOMED CT, which is if you're from the
IT side of medicine, it's a way of coding diseases and findings, just like you have Loink, SNOMED. The Indian government pays, I think, about $1 million a year to license it for anyone in India to use it. So something like that, if could be made for anyone, any physician in India to be able to access it, would go a great way in democratizing it. Of course, with volume, they would be getting a much better price. So the other part of it is utility. And I would like to talk, since one of my heroes, Donna Bedin, was brought about, Dr. Donna Bedin, we need to look at standards of care also. Right now, what is the standard of care? As technology changes, as new methodologies come about, the standard of care keeps changing. An example is in cardiology. Earlier, you would treat a MI patient, stabilize them, send them home, and recommend that they go for an angiogram. Today, the standard of care is primary angioplasty. If you can intervene, if you're in a hospital that has a cath lab, you can take the patient directly to the cath lab, and then measuring quality indices time from door to cath lab. Because evidence-based medicine has shown us that you can improve outcomes. Like that, coming back to evidence-based medicine, it should become a standard of care. Now, doctors should become familiar in using the tools with them. It is, at the end of the day, a tool, just like a stethoscope or ultrasound machine. Having access to a clinical decision system is another tool in your arsenal to use. And why not make it as part of the standard of care? I'm not saying it has to be used for every patient, but if there is any doubt or there are clinical pathways, make use of it. Now, anything basically has the carrot and stick approach. So the carrot is, of course, it will make you a better physician, a better doctor, and ultimately allow you to provide better care to your patient. And tomorrow, if this becomes more and more prevalent, and all doctors in India and around the world have to operate under the threat of medical legal cases. You never know when there's a second guess and you're going to be pulled up for a decision that you've made. And tomorrow, if you have said, yes, this is my opinion, this is my based on my experience, and I have also used this clinical decision support, which has guided me or just helped me in my diagnosis, that becomes an important counterpoint if you're there when there's a lawyer trying to question you and say, how did you do it? CDSs are there, they've been proven, and it's time for us in India, just like, when NABH was introduced, I remember 2007 attending one of the first seminars and realizing that, this is something, yes, it's quite straightforward. It's something that we can do. And now, by and large, there was a lot of skepticism when NABH came in. A lot of hospitals in India, doctors who say, this is doable, in the Western world. In India, with cost, we are looking at low cost. How will we be able to do it, etc. But today, no one thinks twice. If you're a hospital, certain sized, it is not say mandated, but kind of accepted that you go in for a quality program NABH, either entry level or full level, and the new digital standards also, which I'm happy to say we're one of the hospitals that have got the digital health standards too. But why did the digital standard comes in? Because there was like the wild west of different things, people using different kind of standards. But now there's more standardization, and using of CDS is encouraged in the new digital health standards. Beyond that, I know we're pressed for time, but it's time for everyone to go with the program, accept it, and see how they can use it. There are many different types of CDS, and I wouldn't want to promote one over the other. But personally, we've been using UpToDate, and our PGs love it, our doctors love it. So that's it from me. Thank you.
Thank you so much. Maybe I will come back to you a little later for one or two small questions or clarifications. But in the meantime, Dr. Chandramo has just joined us. So I think I would like to give 5 to 7 minutes to Dr. Chandramohan to come out with the same, my question is remains same, that what you feel is the status of patient safety across, you are in the hospital Yashoda, which is the one of the oldest hospital to have NABH accreditation, and whether you have really experienced the CDSS clinical decision support system, and what is your experience, what is your expectation, and how actually CDSS can be promoted among tier 3 or tier 2 towns? Over to Dr. Chandramohan.
Thank you very much, sir. Actually, I'm in the aeroplane, so please pardon me if there is a background noise. And I just landed. So regarding the question, I've been very fortunate to have worked in BLK Super Specialty Hospital for 12 years, which got the NABH accreditation in its second year of operations. And thereafter, we got JCI accreditation also. Then I moved on to a medical college, and we were the first medical college to be accredited as per 5th edition of NABH. And that is the SGT Medical College at Gurgaon. So when I joined as director hospital, I had a big challenge to convince my team to go in for NABH accreditation, because they were in a medical college not tuned to the NABH requirements. So it was a big challenge, but we got it in the first go. Of course, some NCs were there which we addressed and put system in place. Then I moved on to Yashoda, which is one of, as you mentioned, it's one of the oldest hospitals which got accreditation. Madam is also on the board of editorial. So actually, NABH has made tremendous difference to the patient quality here. I think the process which it has put system in place, checks and balances. And what we were doing actually, they have made it very objective. We lay down the guidelines, certain guidelines are laid down by NABH, but it is the hospital which is making its own SOPs depending on the requirement and then putting system in place. So not only the medical errors, medication errors, communication errors have come down, we have also actually made doctors also which were very poor in documentation. And that part has been taken care by the hospital. Then we are doing regular audits where we analyze our mistakes regularly. So 23 odd meetings are taking place in a hospital, of some monthly, some on bi-monthly or quarterly basis, which help us to analyze the errors. And as far as certain tools are concerned, which CDS is concerned, if you permit me for a minute to touch upon this part, actually, I looked at the data in US, 0.5% incidence is there of medication errors itself in the top US hospitals, if they are admitted for even for a day. And as per JCI, 65% of communication errors lead to very serious sentinel events. So these both issues are addressed by these tools at point of care, that we reduce the medication errors. We also reduce the communication errors, which used to happen by passing verbal orders, which NABH actually does not recommend. It has to be in writing, and very clear orders have to be put in place. Then the way we are writing prescriptions, that has also cut down our gross negligent errors. So what these two tools have done, that in a complex patient having multiple comorbidities and patient who's of long-standing diseases, there is a large data set which to be analyzed in a very short time. And multiple medications are going on. So we want to know what is the best investigation modality, what should be the plan of care, and what is the current evidence on this, and what is the drug interaction between various drugs which are going on, recommended by various specialists. All this has helped us with the help of these point of care, these clinical safety softwares. We can cut down on these mistakes and arrive at a very quick decision and recommend the best possible solutions. So what we have done is we have moved from practice-based medicine to evidence-based medicine. And NABH actually has played a tremendous role in this, especially after having moved to the digital platform. We were very slow in BNK. We tried to implement EMR, but we found it a challenge with doctors especially. But this digital format, I think it will facilitate, it will cut down further. Of course, there is a problem with EMR. We are not used to typing. Doctors are not meant for typing. So there is a lot of potential if we can move from voice to text conversion on EMR. we can integrate these platforms with EMR. Alerts can be on mobile, can be sent. I think there is going to be a tremendous potential. I read Nightingale, I have not used personally, but nursing people have found this platform very good, and they have used the AI technology with EMR and these tools, and they have reported that their care plans are very quick now. They can report the incidents and they can resolve it very fast. They can help in cross consultation between specialists. So what I feel is there is a tremendous potential. It is going to improve the not only the quality, make the treatment much safer for the patients, and we will not have much errors if we implement it religiously. So there is a resistance in my experience from doctors. They're not used to it, but I think if we make them user friendly by converting text, speech into text, it will be a better acceptance and we can improve. Over to you.
So now that you are coming up with the Medicity project,
Yes, sir.
how actually you are going to enhance the technology as compared to the existing hospital? I am told that it is going to be a very high-tech hospital.
Yes, we have really focused on a lot of equipment, and it is going to be top of the line hospital. We'll request all of you to visit. And what we are going to do is we are going to focus right from day one on EMR, because we will gain some experience. Already, the current hospital is the first hospital in UP to get accredited as far as digital health accreditation is concerned by NABH. So we are going to move, gain a lot of experience and implement in our new hospitals.
Yeah, thank you very much. And one actually question I wanted to ask Dr. Suresh, that the medication errors has been one of the major component of the overall medical errors, and particularly in the lower and middle income countries. The WHO report says that the disability adjusted life years are more than double from the high income countries. Do you agree with this report of WHO? And if so, how actually can the CDSS help in minimizing the medication errors?
I do agree because, like Dr. Suraj had mentioned that I think it was the Ganeshan that people are not even wearing helmets or seat belts for the basic safety like that. Unfortunately, in lower and middle income countries, the value for life is much lower. In a Western country, one person dies in an accident, it's a frontline newspaper. Here, a train accident, 1,000 people die, it's a second page information. So like that, medication errors are unfortunately sometimes being accepted as a fact of life, and then people are just moving on with it. But only with our quality policies, root cause analysis, and trying to sensitize people to the importance of like using medication error. Now the double read, having one staff nurse pick it up and the other person read it to prevent sound like lookalike medications. So these are quality processes that definitely can reduce the mortality and morbidity of medication errors. And having a CDS which can flag when this disease, and then if it's a digital system wherein they have to enter in the prescription for a particular medication, the system should be able to flag immediately saying that either A, this person is allergic to this, or B, this is contraindicated for this patient. Please get second authorization or raise an alert to someone else.
Yeah, that's right. And Professor Suviraj, actually one limitation which up to date was mentioned was that integration with the electronic health records. But now I'm told that
Right, sir.
new version of the up to date also can link with the electronic health record. Do you see, have you been able to practice this
So,
with the electronic health records?
this feature is available if it can be integrated on the EMR. I've seen the pilot version of it. We have not, I think, fully implemented it here, but it's available. And the nice thing about it is, it's essentially a culture and an ecosystem shift and change we need to bring about. All this wonderful thing, even NABHR that you brought in, it essentially is a culture shift. And it's more than the 683 standards and objective elements. It's actually changing our behaviors, which is the key thing. And that's what we're trying to do through even our, VT prevention protocol. And we realize that it's a lot of hard work that goes in the back end. And as rightly mentioned by Professor Ganesan, Vishwanathan, and Chandramohan sir, they realize the hard work that goes in at the back end and, root cause analysis, corrective action, preventive action, empowering our staff, rewarding those who do good, punishing the people who not apply. It's a daily, labor for us. And what we're in, the one thing that CDSS, the whole model offers is ready, quick, global class evidence at the fingertips of the physician who is sensitized to. So that's the wonderful date and what is we are doing there. And unless we sensitize people and empower them, they're not going to get to that point. And so, in fact, we provide almost sometimes rapid feedback of real-time data to our clinicians, which is the biggest reason for change. Because if we're giving them Sir Gangaram Hospital, your department, your individual data to you, every bed back, and of course, a lot of it is confidential. So what happens is when a certain department sees that its compliance rate is low, its mobility is high, believe me, if sometimes one department, I can't mention it here, from double-digit compliance, they reached 100% compliance just by one memo. But that depends that because the HOD was so sensitized and real and keen to push this quality initiative process forward. So we're discovering many things about human beings and collective, I think, herd mentality, and we're really pushing for culture change here. So Quartersco has done a fantastic thing. They've empowered the integration of the availability of global guidelines or even latest Asian guidelines at the clinician's fingertip. And please remember that in the absence of an Indian guideline, the nearest global guideline becomes the legal default, even in a court of law. So clinicians have to know this, and the lack of knowledge of a clinical guideline will not be excused in the court. So that is how important clinical decision support systems is today based on the evidence. Thank you, sir, for asking this question.
That's very nicely explained. And one last question to Dr. Ganeshan, that the clinical decision support system ideally is supposed to be used in the medical colleges and the DNB, let us say, hospitals. But most of the medical colleges, particularly in the government setup, they are unable to, get this into their budgetary, due to their budgetary constraint, they are unable to, procure this or go for it. So what do you suggest should be the way out so that the application or usage of CDSS can find entry into the medical college hospitals and in the DNB, that is NBE, impaneled hospital? What do you think? How should we go about?
So I can see, can you hear me, sir? I can see two pronged approach to this. One would be already there is a system of subsidized subscription for residents. Whether it would be possible to sort of extend it or subsidize it even more for students in government hospitals, I don't know whether that's possible. That is one thing for the provider to consider. The second important thing is Dr. Suresh was talking about the SNOMED IT system. Whether at the central level, whether government can negotiate with the providers and get a subsidy for access for all the government hospitals. I suspect that is a bigger wheel which will move much slowly. Residents getting it is the immediate sort of solution I see. But I think from the provider also, they can just conduct a lot of contact sessions to raise awareness among the government medical college residents. Because one thing is subscribing for it, second thing is using it. So I think probably raising awareness is still a critical part of improving the usage and genuinely making a difference to the patient care. Thank you, sir.
Okay. So I think with that, we come to the close of the webinar today. And I think we spent 1 hour in getting the useful contribution and opinion from our 4 panelists. So over to Sumedha.
So I would like to thank all the panelists for providing us with the valuable insights. Now I would like to welcome the co-host for the session, Dr. Jennifer Benjamin, Customer Success Specialist, Healthcare C Management, Wolters Kluwer. I would request you to please provide us with the insights on the topic improving patient outcomes with CDS.
So, are you guys able to see my screen?
Yes.
Okay, great. So, thank you for joining us today. Thank you for sticking around. My name is Dr. Jennifer. I am a Senior Customer Success Specialist with Wolters Kluwer. And today, before we conclude this session, let me just give a quick look of how we provide our CDS solution, which is up to date. And before that, let me just quickly browse through what are the major challenges we are facing across the healthcare system today. So the first one, which I want to showcase, is obviously the abundance of the information which is being pushed out every day, right? So as you can see here, at least more than 1.8 million clinical articles are being published every year. And when you have so much of information available, how does a physician make sure that they are accessing the most valid one, the most evidence-based one, right? There could be a position where in regions where there could be no evidence, or there could be a contradictory evidence, and it complicates the decision-making process, right? So, sorry. And the next one we have to think of is the different risk point during a patient's journey while within the institution in a hospital setting. So consider all the complexity. And during a typical patient's treatment, so it starts with the initial diagnosis, then you have a post-discharge care, and the clinician has to review all these details with the patient and decide the next step in care. Now, when an organization is resource constrained, how do they work in a field when they're, and especially if it's a doctor in training or if it's a specialist who is not aware of the case? So we are looking at a complex patient history, right? How do they look for how do they find the answers? And these are the places when the physicians might turn to resources which are not reliable, or it could have out of date information. And next is our healthcare burnout. We cannot ignore this. Taken together, physicians have to, look at so much of individual medical history, diagnostic results, and the circumstances a patient is under. And then along the way, they have to make sure that they are able to efficiently treat their patients. Now, when they have so much weighing on them, they feel sometimes they have to cut the corner just to, treat their patients. This can build a weight on this physician and it can be an added stressor. They could feel like they're delivering a very lower quality of care. They can end up having lower job satisfaction, right? And in most cases, it can even cause them mental health issues and even self-harm. Now, we cannot forget how much we are, encountering with the patients, what could happen to them. Now, these challenges, all of these challenges, they are ending up creating a perfect storm, which can risk the quality of care and patient safety. Now, as you can see on the screen, WHO, it finds that at least 1 in a 300 chance of injury, it can occur during treatment. And there's a 10% chance while being hospitalized. And during surgical procedures, at least 7 million patients are affected and 1 million ends up dying, right? And the New England Journal of Medicine, it is even found that not even half of the patients are receiving what is the recommended treatments. And what happens, obviously, with poor quality of care, variability in care, we end up losing money, especially in medication errors. Across the globe, we are losing $42 billion. And in case of adverse events, we are spending across 15% just to, cover up what has happened. So this is where CDS comes through. So one of the ways the hospitals are tackling these challenges is in adopting a CDS solution, which is a clinical decision support technology. And it helps healthcare professionals access evidence-based information to make the right diagnosis and treatment decisions along a patient journey. So what does it do? In summary, it gives you, again, the healthcare professionals get the latest information. They are able to support, CDS is able to support a clinician in their daily practice, improving the quality of patient care. provides fast answers, right? And it's accessible across various platforms. We were talking about EMR. It can be integrated into EMR as well. And it includes a wide range of resources. It's not just articles or it's not just trials. We also cover guidelines. We cover patient information materials, right? Now, what happens? There was an academic study which figured out how much of an impact a CDS is making, and it's been found that at least a clinician on a daily basis, they have a 15 to 20 clinical question, and around 60% of them are going unanswered. Right now, when you use a CDS, you are able to answer. They are able to find answers to at least 5 or 8 decisions, and they are being able to change it while they're treating the patients. So we are able to find that at least quarter to half of medical decisions is being influenced because of a CDS solution. And obviously it's leading to better patient outcome. Now, in case of a CDS, there are so much of numerous impact and benefits out of it. Now, again, reiterating, this is evidence-based digital tool, and it provides access to the latest evidence and best practice recommendation, right? And it is being curated by global experts, and it is designed to be easily accessible and user-friendly. And it serves as a consistent information, not only for physicians, it is across the care teams. So it can be for nurses, it can be for pharmacists, and any other technician who is around a patient, right? Now, there are certain misconceptions which is being raised. Now, you obviously need a EMR to use a CDS solution. No, it can be used individually as well, and it does not replace a clinician. It has to be used to engage with the patient and to make an informed decision. So it's a very collaborative process, and CDS is aiding you in it. And it's also not just for doctors, as I mentioned before, nurses can also benefit from it, and pharmacists. And it is also not about solving a problem with technology. It is to make sure that you are able to access it easily and efficiently, and it's from the most valuable evidence-based material. Now, this is where UpToDate comes in. So across, we have been a global leader for the past 30 years, and clinicians have relied upon us to access the best clinical content to make best decisions for their patients. And at the heart of it, we have over 7,400 authors and editors across the globe, and they are able to provide the latest information to support our patients. Now, UpToDate has become most used and trusted CDS, and it is associated with improved patient outcomes. And this is out of 100 independent studies which were conducted to evaluate how UpToDate is bringing value. And we have different feedback, and obviously from clinician users, and how much UpToDate has been a valuable resource. This slide, I just wanted to highlight how UpToDate has been making impact across the country, especially in this year from January. So at least 7 million times, this is 75 lakhs of times UpToDate has been used across the country. And if you notice the different percentages, 81% across the different surveys we send out, right? 81% has shared that they trust UpToDate as a point of care resource. 89% believe it is very integral to their practice. And 75% agrees that UpToDate does improve patient care. And 73% also agrees that it helps to prevent errors. Now, what about across the world? Now, UpToDate is being used by 2 million professionals and across 190 countries and different organizations, and we are making positive health impact worldwide. Now, why are we being used so much? Like, why everybody comes after UpToDate, or why it's being so much used? We have to give credit to our robust and wonderful editorial team and the editorial process which we have. It's being done by 7,400 authors, as I mentioned before. And these contributors, they have to be practicing clinicians. They are practicing medicine at the moment, and they need to have work published, and they are teaching medicine too. And while these topics are being synthesized, the evidence and the latest information are taken over from almost 500,000, 5 lakh literature links, and the clinicians are spending time with patients rather than reading the research, right? Now, actionable recommendations are also being provided by our editorial team, and this is across 25 medical specialties. And we are also very transparent. Now, unlike some CDS solutions, our editors and authors are listed right there, and their content and recommendations are also available along with their credentials. And after a content is published, it goes through a peer review process as well. right? And we do not accept sponsorship, our content, or request to publish any third-party content. We are completely unbiased. And this slide showcases what the editorial process is. If you look at it closer, the editorial process is a rigorous process, and this is why 2 million clinicians have trusted us across the globe. Now, expert authors and editors from around the world apply their domain expertise. So, if you notice a topic, or if you're looking for a search, if you're going to search a topic from hematology today, the topic would be written by a hematologist, and it is their expertise which is critically evaluating the literature and evidence as and when it comes through. Now, the team produces original content which provides clear guideline. So, that is our team. They provide clear guidance, the link, and the graded recommendation. Now, this slide, it shows how we have unified our different solutions across the globe. Now, UpToDate has become a global suite of solutions, which we want to refer to as UpToDate Enterprise Suite. And it is designed to unify teams and align decision making. So if you notice, there is a drug reference as well, which is known as UpToDate Lexi Drug, which is also available in India. And this is where it is an online drug reference solution. A piece of it, I want to say, is also being integrated into UpToDate. Now, what is the future and what are we going to do with UpToDate as a CDS solution? It's revolutionizing patient and chronic management in some key areas of medicine to improve clinical effectiveness and outcome. But along the way, we have also found that it's being used in other domains, which is preventive patient care, value-based healthcare. So these are also the areas where we want to improve quality, safety, efficiency, and the delivery of healthcare. And lastly, but not least, we cannot stop from jumping on the wagon of AI. So UpToDate is also setting a standard to have a responsible development of a clinical generative AI. And we are partnering with healthcare community and technology leaders so that we are able to provide answers through what we call AI labs, a testing environment which is going to prioritize reliability, quality, and transparency as always. So that is from my side. But before we go, I just want to showcase a QR code. This is where you can share your feedback. If you have any questions for us, if you want us to reach out to you to give you more information, please, you can always scan this QR code. And I'll also be sharing a link in the chat box. Over to you, Dr. Sumedha. Thank you.
Thanks, Dr. Jennifer, for such an information. Since given the time constraint, I would like to prioritize few of the questions posted in the Q&A box, and I kindly request the panelists to share their insights onto these questions. So, one question which we have, that is, how can technology such as AI, telemedicine, and digital health tool contribute to enhancing patient safety in Indian healthcare? I would request any of the panelists to answer this, please.
AI, if I may, AI seems to be the buzzword, but what we have is not real AI. It's basically enhanced machine learning. The AI cannot come with new findings. It basically connects the dots. AI can be helpful if used correctly, but it all depends on the source of the information, the source of truth. So unfortunately, in India, all doctors have to compete with a pervasive doctor called Dr. Google, because most patients do look up everything on Google, and you don't know how authoritative the results are, what they're reading up. And more than one doctor, and more than a few doctors actually do use Google themselves, because they don't have access to a vetted clinical decision support system. So AI based on something that is proven, like Walter was talking about, using their entire source of data to train AI model, will definitely help in future treatment, because that will allow doctors to be able to cut to the chase, and instead of having to fine-tune their searches, would probably question the UpToDate AI. And because its source is vetted evidence-based medicine, the results should be better. Of course, it will take time for technology to be proven, but I am quite enthusiastic about seeing how this goes.
Thanks, Dr. Suresh.
All right, Dr. Sumedha, can I just comment on that? So
Yes.
we actually, teach protocols as well as how to follow clinical care pathways algorithms. And we do a two-way feedback. We game our presentation so we know what everybody's thinking. There are about three or four things we have found over the years that are very important because we come from a very large country, the most populous country on the planet, and one of the largest medical workforces. And they come from a diverse cultural, religious, as well as personal philosophies. The first thing we tell people is you can own your opinions, but you can't own your facts. And the way people define truth and facts is very different. And we have to start telling them what real time clinical evidence is and how we factually understand that because people even contest these basic things. Because I cannot go into AI before I develop HI, which is human intelligence. And clinicians and healthcare workers, well, highly literate people. So then they have to read the latest clinical practice guidelines, which is not just a medical luxury, it's a legal mandate. People have been taken to court in India because they do not realize the nearest Indian or in the absence of the Indian and national guideline. So surgeons especially are being taken to court because of the lack of knowledge of this. And this has been happening over the last decade. So this is not no longer a matter of me having a better opinion. It is actually being legally valid. And I liked what you told about being unbiased as a service in Walters Kluwer because now everything has a legal, basis as well as a legal critique for that. And then third, we tell people is that you have to know your domain specific areas in terms of not just textbook knowledge, guidelines, and start applying it. And also, please have your own data sets. You cannot base your decision making because the guy in Manhattan or New York bases the decision in the way it's presented on up to date. So we're gathering our own data now, even sometimes on a daily basis, to give us a very a high level of real-time clinical evidence to empower ourselves. And I can tell you from our own data, every month in our large hospitals, about 1,000-bed system, we get anywhere from 30 to 60 cases of venous thromboembolism, of which roughly about half to two-thirds are hospital detected. And that is, we found out because we are doing a daily clinical survey as well as a monthly point prevalence audit, and we check all death summaries, discharge summaries also for clinical evidence. So we find a large number. So India is not, averse. India is not strange or naive to this problem. So the more you look, the more you'll find. Once you develop this healthy way of finding, and we also tell people to be deeply suspicious of everything in a healthy way, suspect everything. That's the only way to stay safe today, not just for yourself, but for your patient also. To check everything, double check, triple check. And that's, developing a very high level of literacy, high level of application. So thank you very much. Because I have a surgery, I hope I can excuse myself.
Dr. Sumit, can I just add a couple of lines?
Yes, sir.
Yeah. Like many things, there are two Indias with respect to AI. There is a part of healthcare system where AI would be very helpful. For example, from my reading, definitely in radiology, in terms of decision making, there are patterns which are recognizable, and so AI is already making big swathes of improvement in diagnostic accuracy. Whereas the large part of Indian healthcare system delivery from the patient perspective is about access to healthcare and being able to talk to a doctor who would be compassionate. And in that, unfortunately, AI cannot fill the gap. So from patient perspective, there is a big gap outside the AI space. Thank you.
Thank you so much to all the panelists for their valuable insights. So, in conclusion, the objective for today's discussion was to explore and emphasize the importance of driving and implementing patient safety in India by improving care, quality, and patient outcome with CDS. I would like to extend my gratitude to all the panelists for their insightful contribution and sharing their expertise with us today. Your participation has been really valuable, and we deeply appreciate the time and knowledge that you have shared. Thank you for joining us and to contribute this important conversation. And in closing, I would also extend my gratitude to all the attendees for joining us today. And I would like to mention that along with the thank you email, you will receive a QR code. We kindly ask you to please scan it and provide us with your valuable feedback, which will help us in enhancing the future sessions. Thank you so much once again for participation.
Thank you. Thank you
Thank
very
you.
much.
And bye, everyone. Nice meeting everyone.